Again, I'm with the National Governors Association. The Center for Best Practices is a nonprofit entity within the association that focuses on helping governor's office think through issues like this. How do you bring your various agencies together, your cabinet heads together to talk about intersection of healthcare services with social services, transportation and housing? And so we're doing a lot of work in that area, in the public health area especially, between public health and Medicaid, and social services, including transportation and housing. Now, I was real impressed with the paper as well, and I'm going to comment about Proposals 6, 7, and 8. I was a Minnesota Medicaid director, and it's good to see Jennifer. Did some great work she did at Hearth in Minnesota in terms of trying to coordinate this effort, and it can be done. Medicaid expansion is not a given, as you know. The Supreme Court decision kind of threw that up in the air unexpectedly. Now, CBO expects maybe 10 million people to be added to that program, but states need to do the business case around expansion of Medicaid. In fact, that's what has to happen. This issue about housing needs to be part of that calculus in terms of, is it in their interest to do Medicaid expansion? Some states are summarily dismissing the idea, and some states are summarily accepting the idea they're going to expand, but some states are now going through that analysis. And this has to be part of that, and you need to make sure that that's part of that analysis. Now, there's a lot of unique programs being developed to serve this new expansion population. You heard about Heartland. You also, Hennepin Health in Minnesota is a very unique program whereby the county developed a managed care organization, or a combo care organization, whatever you want to call it, whereby they're serving a at-risk population of adults without kids, and including covering refrigerators, for example, to make sure that their medications are cold. And that's a kind of creativity that we need in the managed care side. I'll talk more about that in a minute. But clearly, this population has a lot of chronic care needs. And so what you need to do is focus through such things as the health home model, as John talked about earlier, focus on this in terms of these safety net accountable care organizations which are developing throughout this country. These are provider entities that are going to take, or share risk anyway, or take financial risk to serve a defined population. These safety net providers are going to be critical players in this. And the FQHC discussion is a very important discussion, but it needs to go beyond FQHCs. It needs to include safety net hospitals, for example. So a business case needs to be made at two levels. One, at the level of whether or not the state should expand to include adults without kids in Medicaid. And number two is to what extent these optional benefits to provide Medicaid benefits for and connect them with supportive housing, whether or not there's a business case around that. The Center for Healthcare Strategies did a very good issue brief, policy brief. I would recommend that to you. It came out this past June, and I think it's called Medicaid and Supportive Housing, something like that. Well, in fact, they cite some very good evidence that it does work, that there is a return on that investment if you indeed provide Medicaid-type services and in a supportive housing environment. And let me talk real briefly then about the three proposals. Number 6 is a very comprehensive review about the options around Medicaid. Again, the opportunities around ACA is, of course, Medicaid expansion to include adults without dependent children, but also there is more flexibility around one of the programs, home and community-based service programs, 1915I. And if you're familiar with the waivers, which you want to get something complicated, talk about the waivers within the Medicaid program, but 1915I is a very important opportunity for states to do what's called a state plan amendment, which is not as complicated as submitting a waiver, to provide home and community-based services. And there's more flexibility that state Medicaid agencies now have around that to provide that kind of service within a home and community-based setting. Certainly, states are focusing on this because of the Olmstead decision and because it just makes sense to do what they call rebalancing of institutional care and home and community-based services. So states, and especially Medicaid agencies, are looking for opportunities to do that very thing. There's incentives in the new ACA for states, for some states, to balance more effectively between home community-based services and institutional services. So in 1959, I'd recommend that the report talk about that, at least reference that opportunity as well. And then there's other things going on. John talked about the various things. One is states are now going through the process of thinking through whether or not they're going to apply for what's called state innovation model money. There's planning money and implementation money. And CMMI, the Center for Medicare and Medicaid Innovation Center, is offering those resources to states to think that through. It's very important as states do that. And this is a multi-payer, multi-faceted effort to transform healthcare within the state, not just Medicaid, certainly. And the whole issue of housing needs to be introduced to that process. They're going to select 25 states for planning sometime in December and 5 states for implementation and testing. The housing component should be part of that analysis that states are doing. And in fact, so you need to identify, I think, that as an opportunity as well. There's, in terms of number 7, FQHC piece, that's a very well done document, but need to go beyond FQHCs and talk about health home model and reference that a little more, I think, in the paper. John talked about it, the importance of that. Medicaid is focusing on health homes in terms of that being the opportunity to coordinate care for people with chronic conditions. And so that is how you best use targeted case management services or rehab services in the context of a health home model. I think the paper needs to talk about that a little bit more. And also because there's been issues around targeted case management in the past, from misuse, inappropriate use of some states of targeted case management. So it needs to be targeted to people with the right population, and through health home models or through other ways to make sure that that service is used properly. And also the issue of physical and mental health integration, which is not very effective. FQHCs are in a good position to do a lot of that integration, but it also needs to include other services too, other social services, transportation, and other things, not just housing and healthcare services. And you're seeing develop a special, these safety net ACOs, as I mentioned before, like Montefiore or Hennepin Health and others, where public hospitals are developing these models very effectively. Number 8 is on the managed care piece. The question, and the right question came up, is can managed care organizations do this? It's not so clear that they can. But what you want to see is alternative models develop, alternative managed care models. Counties are developing. This Hennepin Health is a model, as I talked about, is a managed care model. In California, counties have developed these models. Minnesota, not beyond Hennepin Health, counties have developed managed care models. What you want to encourage is alternative models around managed care, not just the more traditional insurance models. But with the traditional insurance models, what you want to see is make sure that MCOs are developing a unique product or unique approach to serving this population. Certainly for duals, Medicare and Medicaid duals, that's going to be a unique model. But when they develop arrangements for adults without dependent children, states need to make sure that indeed they're developing products specifically for this population, at-risk population. What we talked about a lot in Minnesota was, and we brought Veterans Administration together with the housing people, with employment security. Employment is a critical part of this process as well. We talked about at-risk populations, including housing and health care. There's another, and I know I talked too much about Minnesota, but there's another great program called the Network. The Network provides for an integrated approach of housing, employment, child support, and health care, mental health services for people coming out of prison. It's aimed at the African American community, assimilating back in the community, coming out of prison. I would recommend you look at that model, which has a strong housing component to it. And so, in fact, one thing that the report does talk about is the importance of MCOs to provide services here and to have incentives for MCOs to provide services. The best way to give that incentive to them is to risk adjust. their payment, making sure that the payment that they get is sufficient. Risk adjust, not just based on their acute care needs, medical needs, but on their functional needs as well. We need more sophisticated risk adjustment in general on social determinants and around and demographics. And so risk adjustment needs to be, I think, a much more sophisticated approach, and I would recommend that the paper address that as well. Thank you.
Thank you. Could I, before going on, could I ask you, what do you think as as states are making these decisions about how to respond to the Affordable Care Act and, how and what mechanisms to use to cover previously unserved populations and so forth? I mean, what as a state Medicaid director do you need to know? What kind of information would you need to have, and what could CMS do to help you make those decisions?
That's a very good point, because Medicaid directors, as was said earlier, oftentimes are just focusing, of course, on getting their day-to-day business done and providing acute care services. They need to find time to sit down with other agencies and other organizations to talk about this very issue of providing an integrative approach. And so what they need is information. They need evidence, number one. And that paper reference talks about evidence in Chicago, evidence in Massachusetts about how there's a return on this investment, and how housing, supportive housing, and providing Medicaid services, which are optional services, by the way. So there has to be an analysis done here. They need information about what is the value of providing those services.
Is that evidence? Do you think that evidence base is strong enough? Is it persuasive
no, it's
enough?
not strong enough. But I think, again, the Center for Healthcare Strategies started to uncover some of that evidence in a couple of sightings that they had in their paper, and so that's the first time I've seen it. I've been involved. I was in Medicaid and running healthcare programs in Minnesota for 9 years, and never saw any data. So we worked around how important it is to provide for Medicaid, to provide this kind of support. We never saw that kind of analysis. So that data needs to be made available.